So thanks for the introduction. I'm very happy to be back. I presented last year on Carbovir and abacavir, and so I'm excited to extend that. When I told my husband I got accepted to do an oral presentation, he's like, oh yeah, of course, because you got to do that talk about that really important drug. So he understands that this is a fun place to be. So no disclosures. And just like with any good presentation, setting the stage for why this is important, although I'm sure that this kind of goes on, it doesn't really need to be said in this group, but globally, we have about 1.4 million children under 15 that have HIV, and that was as of 2024. The amount of these same kids that are living with HIV, only 55% of them are on actual antiretroviral therapy, which then makes more sense because then we see only 47% are virally suppressed. So there's a huge treatment concern that exists there. There's also just inherent concerns in this very vulnerable population since they are reliant upon caregivers to provide treatment, and also the access to treatment, which can just be limited in the form of delayed drug development for our pediatric friendly formulations. So as we start to have more developing pediatric formulations for the treatment of HIV, we really should be thinking broadly about how can we also increase the objective adherence measures so that we can ideally improve the monitoring outcomes for these kids. Abacavir and lamivudine, as was already described, are two components of the treatment in pediatric ART for HIV, and they are recommended by both the WHO as well as DHHS. As with all of our NRTIs, they are administered as prodrugs and require intracellular activation to their triphosphate forms, which is what actually is the active component. For abacavir, it is Carbovir triphosphate that is doing the work. And so for most of the presentation, I don't know that I actually speak too much about abacavir specifically, but when I'm talking about Carbovir, that is what I'm referring to, the active form of abacavir. The cellular pharmacology for really all of our antiretrovirals in this pediatric population are limited, but this is true for our abacavir and our Carbovir, or abacavir and lamivudine group. But we also have to even think more about what does that mean for our different matrices, and it's even further limited when we think about DBS, which presents more of a practical tool for measuring intracellular drug concentrations. So I would like to talk about IMPAACT 2019, which was a study that was designed to try to address some of these gaps. So IMPAACT 2019 was a phase 1-2 study that was designed to evaluate the PK, efficacy, safety, tolerability of dolutegravir, abacavir, and lamivudine, so Triumec, in children less than 12 years old and those weighing at least 6 and no more than 40 kilograms, and these children had HIV. Those who were enrolled could be either ART naive or they had been virally suppressed on at least 6 months of ART treatment, where most of our cohort fell into the latter of the two inclusion criteria. When they were enrolled in one of 5 weight bands. The weight bands, as shown, what they were receiving is based on the weight bands they were assigned. So if they were within the 1 to 4, so less than 25 kilograms, they were receiving either 3 to 6 tablets of the dispersion form. If they were above 25 kilograms, then they were receiving the film-coated immediate release form, which is similar to what we think of for our adults. The overall objective, so what I'm presenting today, is an exploratory analysis of IMPAACT 2019. So we were wanting to understand the intracellular concentrations of Carbovir and lamivudine in DBS and PBMCs among these children, and those among the children in those different weight bands. The DBS and PBMC samples were collected in blue across all of our participants. Those who were in the red, so our weeks 8, 16, and 20, were those collected additionally because they had a known M184 mutation. The assay that was used to measure the Carbovir and 3TC was the same. It was one that I was so fortunate to be able to develop, so very excited to be able to put this into use. The BLQ values that we had obtained were imputed as half of the LLOQ, which for Carbovir is 5 femtomoles per sample, and for lamivudine is 0.1 picomoles per sample, and I will include that at the slide so you don't have to remember it. We created a linear mix models that was used to estimate the geometric means and then compared across the different weight bands and the study weeks. So going through the results, and just to remind everybody, this was very preliminary, so this may not be super exciting, although very exciting for me. I'm sure Christina would say the same. Just so we can, have some expectations tempered and knowing that there's more to come. So the baseline demographics shown for our entire cohort is in the box in red. So you can kind of focus on that. The rest is just stratifying by the different weight bands. We had 55 participants that were included, which represented 314 DBS samples, 304 PBMC samples. From the cohort, we can see that over 50% were male, 67% were Black, 31% Asian. Not shown here, but just for reference, since I did mention as part of the collection, but 7% of the cohort had the M184V mutation. Of our samples, all of our DBS samples were quantifiable, and I will go through specifically which samples from our PBMC groups were BLQ. So let's start with our Carbovir concentrations, looking first by study week. Our Carbovir concentrations, and also just to orient you, I'm always going to have DBS on the left, PBMCs on the right. So all the result slides will be oriented this way. So for our DBS samples with Carbovir, we can see that there was a comparable concentration across the study weeks, across the participants, where in the blue is representing the different points for each week, but the gray shaded region shows our overall geometric mean with a 95% confidence interval, which is also listed at the bottom of the slide. So 583 femtomoles per punch is our overall geometric mean for the Carbovir in DBS. The PBMC results were similar, so looking now at the left side, we can see that, again, the levels across the weeks, across participants were similar. The overall geometric mean, again, shown in the gray region for Carbovir in PBMCs was 126 femtomole per million cells. I guess, unfortunately, where I said I'd have a reminder, most people can't see it, but it is, again, 5 femtomoles per sample for our Carbovir, which I think is really incredible when you see our ranges, since it was quite high, so we were able to easily quantify all of them in DBS. Unfortunately for PBMCs, there were 10 that were BLQ, and so they are actually not shown, but just so you can kind of visualize what the overall trends were. For our weight band groups, again, we saw comparable levels, comparable concentrations across the weight bands. So again, DBS being shown on the left, we can see that the biggest difference that existed was between weight band 4 and 5, where there was still overlapping in our overall confidence interval. So we feel that this is likely not clinically meaningful. So again, we feel confident to say that there is consistency across our weight bands for our DBS cohort, which is also true for our PBMC cohort. The gray region, again, showing our overall geometric mean with our overall 95% confidence interval. Similar trends were shown with our 3TC concentrations. So again, looking first at our study weeks, we can see across our study weeks, there's similar concentrations for lamivudine in the DBS samples, and then again, there are similar concentrations across weeks in our PBMC samples. Our PBMC samples had 6 that were BLQ, so there was just a few less. And again, our LLOQ for reference is 0.1 picomoles per sample. So looking at our overall geometric mean, we had 8.99 picomoles per punch for our DBS and 7.16 picomoles per million cells for our PBMCs. Weight bands, again, did not show any difference. So you can see that regardless of the weight band, we did not see any difference in the concentrations of 3TC in DBS or PBMCs. So we'll stew on it for a second, but overall, there is a consistent finding that we are seeing comparable levels across the different weight bands and weeks for both matricy and for our analyte. Here's the overall results that I've tabulated, where the IMPAACT data is on the top, reference data on the bottom. Our reference data is our adults there's 12 adults living with HIV who had been receiving Triumec with at least 75% adherence. And so you can see on the top that our value of 583 that I previously reported for Carbovir and DBS is quite a bit bigger than what we see with our adults. So across our two matrices for Carbovir, we have higher levels of Carbovir present, whereas for our 3TC, it's actually pretty similar. So takeaways from what we have for this very preliminary model is that, first, everything was quantifiable in DBS. Yay for me. Hitting all the microphones. Yay for me, since this was a passion project to be able to see this validated method be put to use. And so all quantifiable in DBS with a very small amount that were not in our PBMC group. The overall trends across weight bands and study visits were similar for both Carbovir and Lamivudine in DBS and PBMCs. In our Carbovir group, we had a higher concentration in our pediatric group compared to adults, but for Lamivudine, they were comparable. Of note, and perhaps I should have pointed this out sooner, our Carbovir concentrations did not accumulate over time, which I guess is also inherent to the fact that concentrations are similar over 48 weeks, but that also indicates that it's not accumulating, so likely has a short half-life compared to something like our tenofovir, which we know has a much longer half-life in red blood cells. So something to keep in mind and also to stay tuned for. The future research probably doesn't need to be said, but going to continue to explore additional modeling, see what else can be influencing these intracellular concentrations in our pediatric population. So big thanks to IMPAACT 2019 protocol team, sites, of course, the participants who make the work possible, to my ROC, Christina, who's my mentor, and all those who have helped out at the Colorado Antiviral Laboratory and back at home base in Colorado. And thanks. Happy to be a part of the questions.